Now we will talk about the last issue in this program, which is imaging of the larynx. And we can image the larynx by CT and MRI. Both have their advantages. Whenever we examine the larynx by CT, we should have what is known as the scanogram, which is just a scout or plain X-ray for the area to be examined. And we usually align the sections parallel to the laryngeal ventricle, starting from the mouth floor and ending by the appearance of the trachea. We usually proceed or cover this distance every 2 to 3 millimeter slice thickness, and we may use the 2D and 3D reconstruction for the images. By MRI, we use what's known as the head and neck coil, and it's very important to have the T1 and T2 weighted images, and also we should suppress the fat in some of the images in order to see the lesions before and after injection of contrast material. Then the anatomy of the larynx, we have three important anatomic landmarks, which are the hyoid bone, the thyroid cartilage, and the cricoid cartilage, and some of the muscles. We start by the CT sections, and this is the inferior border of the mandible, and this is the mouth floor muscles. This is the start of the hyoid bone, and you can see the tip or the upper part of the epiglottis, and here you can see a fold which is known as the glossoepiglottic fold, connecting between the epiglottis and the mouth floor muscles, dividing this area space into two components, which are known as the valleculae. Then the epiglottis continues inferiorly as the area epiglottic fold, bordering medially the piriform fossa on both sides, and this is the laryngeal lumen. Whenever you go more inferior, you can see this is the epiglottis, this is the pre-epiglottic space, and here you can see the hyoid bone, the mouth floor muscles, and this is part of the submandibular salivary gland on both sides. This is the sternomastoid muscle on both sides. Then if you go more inferiorly, you can see the strap muscles, and these are 4 muscles, and we cannot discriminate these muscles on imaging, but we usually refer to this group of muscles as the strap muscles. This is MRI T1 weighted image. The CSF inside the spinal canal is black, and this is CT, of course. Then you can see the strap muscles by CT and the strap muscles by MRI. This is the sternomastoid muscle, as you all know. Then you go more down. This is the epiglottic fold. This is the piriform sinus on both sides. And then you reach the level of the true vocal cord. And here you can identify the arytenoid cartilage. This is the thyroid cartilage. This is the true vocal cord. And this is the anterior commissure. Then if you reach the level of the true vocal cord identified by the appearance of the arytenoid cartilage, you can go a little bit to the proximal section. Then you can identify the false vocal cord. The false vocal cord is just a mucosal fold. It is filled by fat, and it lies immediately above the true vocal cord, separated from the true cord by the laryngeal ventricle. And this appearance in the coronally reconstructed image, you can see the true vocal cord, you can see the false vocal cord, and you can see the site of the laryngeal ventricle. In the era before CT and MRI, we used to perform what's known as tomography of the larynx. This is just a plain X-ray using the tomogram, and by this technique we can diagnose many of the abnormalities of the larynx. Here you can see the true vocal cord and the false vocal cord, and in between you can see the laryngeal ventricle on the normal side, but in the opposite side you see a laryngeal cancer which has infiltrated the true and the false vocal cord as well as the laryngeal ventricle. Then this is the true vocal cord identified by the arytenoid cartilage, and here is above the true vocal cord you can see the false vocal cord filled by fat. Then lower down below the level of the true vocal cord you can see the cricoid cartilage, and this is the infraglottic larynx, and you can also see the thyroid gland. You see also the sternomastoid muscle, the internal carotid artery, and the internal jugular vein. Also, the anatomy comparing the CT and MRI. This is MRI T1 weighted image because the CSF is black. This is also T1 weighted image. And one of the most important informations about MRI that T1 are designed for anatomy and T2 is designed for the pathology. Because in the T2 weighted image, all the lesions containing water will appear bright, while the T1 weighted image concerns about the anatomy. Then you can see the anatomic details in the T1 and the pathologic details more better on the T2 weighted image. This is also the T1 weighted image. This is the arytenoid cartilage, the true vocal cord, the sternomastoid muscle. And by MRI, this is the arytenoid cartilage and the true vocal cord of both sides. One of the diagnostic issues about invasion of the laryngeal cartilage by cancer is sclerosis in the CT scan. If you see the arytenoid cartilage is sclerosed compared to the opposite one, you know it is invaded. And if it is sclerosed, it will appear like cortex in MRI. And the cortex in MRI appears black in the T1 and black in the T2. Then you will see the arytenoid cartilage, in spite of being bright like this, it will appear black. Then you know that has been infiltrated by the cartilage. Then some of the pathologies that can be seen in the clinical practice, one of them is the laryngecele. And the laryngecele has three main types: the internal one, which is inside the larynx, the external one, which is outside, and the mixed one. This is an example of an internal laryngecele, this is an external laryngecele, and this is the mixed laryngecele. Actually, you all know that laryngoceles are usually filled with air. It is written in our books that laryngecele may be filled with air or fluid or air fluid level. But my colleagues in the ENT department said that the lesions that are totally filled with fluid in the larynx are called the saccular cysts. And the laryngecele should contain only air, and whenever it is obstructed, it may contain air fluid level or secondary infected. Then whatever the terminology, but I say what's written in our books. They thought that the laryngecele may be filled with fluid, like this example, or air fluid level. And bilateral laryngoceles occur in this percentage of patients. Secondary infection may occur in 10%, and in 15% the laryngoceles may be complicated by laryngeal cancer. And this is a large fluid-filled laryngocele or saccular cyst, which is located inside the larynx. This is an infected laryngocele with air fluid level on the right side of the larynx. Then we came to the main issue, which is the laryngeal cancer, which is very common in the supraglottic area, less common in the glottic area, and least common in the subglottic region. Laryngeal cancer is usually diagnosed by CT or MRI based on the presence of a solid mass infiltrating any part of these parts of the larynx. Then the role of imaging is to delineate the site and the extent of the lesion, and to identify invasion of these spaces, in particular the pre-epiglottic space, the paraglottic space, and the extension to the anterior commissure, as well as invasion of the laryngeal cartilages. The previously used imaging modalities like conventional tomography and radiography, barium swallow, did not contribute now for much diagnostic tools, but the originally used nowadays are the CT and the MRI. This is an example of a normal barium swallow showing the valleculae and the piriform sinuses, and this is an example of a piriform sinus carcinoma invading the larynx by conventional tomography and by barium swallow. Then our role in cases of laryngeal cancer is to assess the tumor size, extension into the pre-epiglottic space, the paraglottic space, anterior commissure, and cartilage invasion. This is a CT scan of a left-sided laryngeal cancer infiltrating the area epiglottic fold. You see a mass, and the most common mass met in the larynx is the laryngeal cancer. And you see a mass infiltrating the left area epiglottic fold, and This is another case of supraglottic cancer infiltrating the right side of the epiglottis. This is the epiglottis and this is the right side of it. Then the lesion continues along the aryepiglottic fold, invading the paraglottic area between the aryepiglottic fold and the thyroid cartilage. The sign of invasion of these spaces, the preepiglottic space and the paraglottic space, is the affection of the fat. And the invasion of the fat is much more detected by MRI compared to the CT scan. Because you all know that fat in MRI in the T1 is bright, and the tumor in the T1 is black because of its water content. Then you get a marked contrast between the bright fat and the tumor which is black, and you can easily detect the fat invasion by MRI. Then this is the same case. Also, one of the major rules of the radiologist is to detect the metastatic lymph nodes. Then in this case, you see the invasion, the supraglottic lesion, and this is a metastatic lymph node ipsilateral to the tumor side. This is another case of supraglottic carcinoma infiltrating the epiglottis, and these arrows points to invasion of the pre-epiglottic fat. And also it is continuous along the aryepiglottic fold, reaching down to the level of the false vocal cord. This is the false vocal cord identified by its fat content, and this is the false vocal cord which is infiltrated, and you can easily notice that the thyroid cartilage is sclerosed compared to the thyroid cartilage on the opposite side. That's to say this cartilage has been infiltrated by the tumor. Actually, whenever you can obtain sagittal reconstruction and the coronal reconstruction by CT and also in MR images, it is very helpful in the diagnosis. This is the true vocal cord which looks normal, similar to the opposite one, but this arrowhead points to sclerosis of the arytenoid cartilage, which is highly suggestive of being invaded. The coronal images showed the tumor tissue obliterating the paraglottic fat. Compared to the normal side, this is the true cord, this is the false cord, this is the laryngeal ventricle, and the paraglottic fat is preserved. Then MRI is very good in this particular domain. This is the sagittal T1 weighted image of the larynx by MRI. You can see the epiglottis and reaching down to the level of the anterior commissure, and this is very helpful to detect the relation of the lesion to the site of the anterior commissure. Also, the coronal images are very good in this particular domain. Then you came to the glottic cancer, and this is the case of right-sided glottic carcinoma infiltrating the true vocal cord as well as invading the anterior commissure. You know that the thickness of the anterior commissure should not exceed 2 mm. The distance between air and the cartilage should not exceed 2 mm. If it is wide like this, you know that the anterior commissure has been infiltrated. Another case of right-sided true vocal cord invasion and infiltration or extension into the anterior commissure as seen by CT scan. The subglottic cancer is the least common of the laryngeal cancers, and you can see here a soft tissue mass invading the right half of the cricoid cartilage with extra laryngeal extension medial to the thyroid lobe. Then the carcinoma, which affects all levels of the larynx, is known as the transglottic cancer. As you can see in this example, there is a big mass in the supraglottic area infiltrating the thyroid cartilage, extending down to the true vocal cord, marked by the presence of the arytenoid cartilage, then going down to the cricoid cartilage, and you can easily identify that the cricoid cartilage is sclerosed compared to the opposite one, denoting its invasion. This is what we call the transglottic carcinoma. Then some of the lesions that are relatively rare compared to the laryngeal cancer affecting the larynx, one of them is the laryngeal hemangioma. Laryngeal hemangioma is diagnosed by two imaging characters. The first one is the presence of minute calcium inside the lesion, representing calcified philippuli. And if you inject a contrast material, hemangioma is a vascular lesion, it will enhance markedly after injection of contrast material. These are the two diagnostic landmarks of hemangioma in the larynx. Then the polyps, like this one, and it is easily identified by CT and also by endoscopy, and easily be taken as a biopsy. Then one of the lesions that occur also in the larynx is the chondrosarcoma and chondroma. Actually, we cannot discriminate both lesions on imaging unless you can get some of the malignant features like metastatic deposits and so on. Then you suspect the possibility of chondrosarcoma. And this is a case of chondrosarcoma infiltrating the thyroid cartilage on the right side. The only diagnostic landmark of chondrosarcoma is the presence of a soft tissue mass that contains matrix calcification. Anywhere in the body, a malignant lesion containing matrix calcification, we assume that it represents a chondrosarcoma. This is two different cases of chondroma obtained from the literature showing a calcified lesion in the larynx. Both are located posteriorly. They look benign, but we cannot rely upon this. We should have a biopsy and to verify the nature of the lesion. Liposarcoma also can occur in the larynx, and the basis for diagnosis of liposarcoma is the presence of a mass which has malignant features containing fat. And besides the fat, you should identify other tissues. If you identify other tissues, this is the liposarcoma. If you identify fat only, this is just a lipoma. But if fat is combined with other soft tissue material, then you may think about the liposarcoma. Metastasis can also occur in the larynx, and the basis for diagnosis is the well-known primary malignancy. You know that melanoma, renal cell carcinoma, bronchogenic, and breast and so can send metastasis to the larynx. And this is a case of a soft tissue mass infiltrating the region of the true vocal cord. And without history, you can diagnose this as carcinoma of the larynx. But if you know that the patient had cancer bladder, you may suspect the possibility of metastasis that has been proved histologically. Another case of bronchogenic carcinoma metastasizing to the larynx, and you see that the right area epiglottic fold is markedly thickened down to the level of the true vocal cord, representing metastatic deposit to the larynx. Then lymphoma can also affect the larynx. This is a case obtained from the literature. Bulky soft tissue masses are infiltrating the larynx, encroaching on the laryngeal lumen. And this is one of the usual cases met in the clinical practice. We see a mass in the supraglottic area, and this mass was suspected to represent the carcinoma of the larynx, which is more common than the lymphoma of the larynx. But on biopsy, this was a case of non-Hodgkin lymphoma. Then by this, I have finished the original talk, and we are left with some of the quiz cases as used to see by the end of the lecture. Then what do you think about this structure? Yes, submandibular salivary gland and strap muscles and glossoepiglottic fold and epiglottic fold. What do you think about this lesion? Yes, we usually diagnose transglottic cancer whenever you see the cricoid cartilage. If you don't see the cricoid cartilage in the provided images, you know that this is supraglottic with glottic invasion. And you can see the arytenoid cartilage is sclerosed, denoting its invasion. Also, the thyroid cartilage has been invaded with extension of the lesion into the strap muscles. Then this is a fluid-filled lesion inside the larynx. You may call it saccular cyst or an internal laryngeal seal, according to the radiology literature. What do you think about this lesion? Right? Cyst, yes. Which one? Yes, very good. This is the thyroglossal duct cyst. It is not inside the larynx, it is outside the larynx at the level of the hyoid bone. This is the most common location for the thyroglossal duct cyst. And what do you think about this mass inside the larynx? Carcinoma? Yes, we usually consider any soft tissue mass inside the larynx as carcinoma unless we have other features of the rare lesions. In this mass, you can see two calcified spots within the mass representing philippoli, and then you may assume that this is a hemangioma, and this was hemangioma of the larynx. Then what do you think about this case? Yes, this is a chondrosarcoma. Yes, chondrosarcoma of the cricoid cartilage. Then what do you think about this case? You see only lymph nodes. This is true, okay? This is lymph nodes in the neck, and the lymph nodes may be due to so many pathologies like the metastasis, sarcoids, or lymphoma, and others. But I put this case just to let you know where to look the lymph nodes in the neck. There are three major sites for lymph nodes in the neck. The first one is the group below the chin of the mandible, which is known as the submental group of lymph nodes, and the group related to the submandibular salivary gland, which is known as the submandibular salivary group, and the last group is lie deep to the sternocleidomastoid muscle. This is known as the deep cervical lymph nodes. Based on the relation of the nodes to the hyoid bone, you have the upper deep cervical and the lower deep cervical lymph nodes. Sometimes when there is generalized lymphadenopathy, you may have lymph nodes inside the parotid gland. And you know that the parotid may contain lymph nodes, and the lymph nodes may be enlarged in the course of enlarged lymph nodes in the neck. This is cervical lymphadenopathy, which can be verified by lymph node biopsy. Then what do you think about this case? This is a soft tissue mass invading the larynx. First possibility is carcinoma, and is this supraglottic or glottic or transglottic? But as I have said, you still don't see the cricoid cartilage. This is a supraglottic cancer invading the glottic area, and this is the fluid-filled lesion inside the larynx, maybe internal laryngeal seal or saccular cyst. And what do you think about this? Yes, which one? Cyroglossal, very good. This is the classic site تقريبا of the cyroglossal duct cyst, which is located at the level of the hyoid bone. It lies outside the larynx, the cyroglossal duct cyst. Then what do you think about this case? Supra ولا glottic? Supraglottic cancer infiltrating the false vocal cord. The true vocal cord is okay. Then this is a supraglottic carcinoma. Then some of the anatomic details. What do you think about this? Submandibular, and this hyoid bone, and this vallecula, very good, and this strap muscles, yes, and thyroid cartilage, arytenoid cartilage, sternocleidomastoid muscle. Thank you very much.